Okay, so today we continue with our presentations on abdominal imaging with a very interesting topic, which is solitary liver lesions imaging. Dr. Jean, your colleague, will present the talk to us. The floor is yours, Doctor.
Hello everyone. Today I will be talking about solitary liver lesions. There were many in the satin. I just try to uh, summarize it as much as possible.
I will shift to no problem.
Focal liver lesions, the ones that I will be talking about, only two types, solid type and cystic type. There are also mixed type, but I just choose these two types. The solid one are subdivided into benign and malignant. In the benign lesions, I only talk about three of them, which are hemangioma, focal nodular hyperplasia, hepatic adenoma. Later on, I will talk about them one by one. And the malignant one, hepatocellular carcinoma and fibrolamellar carcinoma. There are many more, but I only choose these lesions. Hemangioma, this one is the most common benign liver lesion. More common in female, usually asymptomatic, but sometimes they become symptomatic when they are very large, like go up to 10 cm. They cause pressure and pain. The ultrasound features of hemangioma, as it is blood content, it will be hyperechoic. But in fatty liver, in fatty liver there is increase of echogenicity, it will mask the echogenicity of the hemangioma, so it will appear hypoechoic in steatosis. In Doppler, it doesn't take vascularity.
Which is surprising.
There are two types. Sometimes, as I read, if the caliver, if it's cavernous type, the caliver is larger, and so there's blood flow. Sometimes they take vascularity, but most of them they don't.
The surprising thing on hemangioma on a Doppler, the capillary one, the more common one, shows no flow, okay?
Yeah.
But try to do a biopsy for it. It will bleed like hell.
Yeah.
It's because of its capillaries, you don't see the flow on the Doppler because it's very tiny. But if you touch it, it's a very hemorrhagic tumor. I hate it when we do biopsies and turn out to be hemangioma. Usually the patient have some bleeding and some problems like that. Anyway, good. Yep, if there is a suspicion of hemangioma, you don't do. But sometimes we are not sure that this lesion is hemangioma or not, because there are something like hyperechoic metastasis or hyperechoic tumor. You see tumor markers increasing, lesion increasing in size. You have to do the biopsy, okay? And when there is bleeding a lot in the biopsy, I know this is a hemangioma, and the histopathology comes hemangioma.
But they usually don't require biopsy because they have characteristic features.
Yeah.
On CT, it is we have pre-contrast CT and post-contrast. The post-contrast, there are three phases: arterial, venous, and delay phases. Each phases have different features. All the lesions will require this triphasic CT for getting the diagnosis. Here, hemangioma appears as hypoechoic.
Hypodense.
Hypodense, sorry. These three images are post-contrast. This one arterial, portal, and this is delay phase. In the arterial phase, which is the contrast is given, there is peripheral enhancement, but the pattern of this enhancement is not like a complete ring. It is discontinuous and nodular, and it starts at the periphery. As the time goes by, there is gradual filling of the lesion till it will completely fill in. But at which phase it will completely fill in depends on the size of the lesion. The larger the size, the more time it takes to fill in. The smaller the size, the less time it takes to fill in. And this pattern of enhancement that starts from the periphery and goes toward the center is called centripetal enhancement.
So it must be careful. It must show peripheral, nodular, interrupted centripetal enhancement. لازم هاي 4 criteria: peripheral, nodular, interrupted, centripetal. Okay? If it was not interrupted, this is not a hemangioma, think tumor. If it was not interrupted, peripheral, centripetal, nodular, but continuous. Okay? Think maybe tumor with central necrosis. Okay?
Here's the comparison between two different sizes. This is the larger one. This one is a smaller one. You see here the smaller one is completely filled in at an earlier phase, while the larger one, it might fill in later stages.
And what else? What else here is different from the previous image? This is MRI. The previously was CT.
Yeah.
So you'll have the same finding on MRI and on CT scan.
And here you see in the arterial phase, it's nodular. It's not completely, it's not continuous.
Yep, exactly.
Does it require biopsy? It doesn't usually require biopsy, or it's contraindicated because of the profuse bleeding. And does it require surgical resection? Any idea? Yeah.
If it is symptomatic, if it is liable to rupture like a really big hemangioma or previous episodes of bleeding, so it will need some sort of intervention, surgical
Usually
resection.
the larger ones cause symptoms, and the larger ones are has propensity to rupture. The second lesion is focal modular hyperplasia. This we talked about hemangioma. This was the first most common benign lesion. The second one is this one. Usually in young adult women, arises as a result of congenital vascular malformation, usually asymptomatic. Understanding the histological features of this lesion, focal modular hyperplasia, will help you understand the imaging features. So I will talk about the histologic features and then go to the imaging features. Let's say this circle is a lesion. Each rectangle representing the hepatocyte. It's composed of normal hepatocyte, just hypertrophied. That's why it's named hyperplasia. And the center has a scar. This scar is a fibrovascular scar. These are the vessels, and this is the fibers. Okay. There's a central artery with branching vessels radiating toward the periphery of the scar within the fibrous septa. Why it's important to understand this? As these liver cells, this hypertrophied hepatocyte are normal liver cells, just hypertrophied. So in most imaging, either ultrasound, CT, or MRI, this lesion is isoechoic because it is just normal hepatocyte. And the central scar, since it's a fibrovascular scar, it's a kind of watery scar. So, I didn't talk about this. These are malformed bile duct. These are vessels. Since this is a watery scar, it will appear T2 hyperintense. It's a watery scar. In MRI, I mean. And also, the supply of this lesion is from hepatic artery. It doesn't have portal vein, and also drained by hepatic vein and malformed bile duct. Since the bile ducts are abnormal, so there will be slower biliary excretion. This will help you understand why in hepatobiliary phase, which is a phase that starts after 20 minutes of contrast injection, hepatocyte-specific contrast.
Hepatocyte-specific. Yeah, so it's not gadolinium. There is contrast in MRI. It's hepatocyte-specific. Okay, but it's not gadolinium. So it will take 20 minutes. Yeah, you are correct now.
Also, understanding this is another thing basic you have to understand the lesion, why it appears in certain ways. You have to understand what is OATP transporter and the role of OATP transporter. Again, let's assume that this is a normal liver cell. This is OATP transporter on the surface of the cell. What happens when contrast agent, which is hepatocyte specific, given, it will be transported into the cell by this OATP transporter and then excreted through bile duct. And what happens in the case of FNH? We are talking about FNH. This is a hypertrophied cell, so there will be increased or overexpression of the OATP transporter. So there will be a massive amount of contrast transported into the cell, and there will be hyper enhancement of this lesion in again hepatobiliary phase. And also this will help you differentiate FNH from other lesions, but by the OATP transporter. Let's assume this is another lesion, the cell of another lesion. It doesn't have OATP transporter on its surface. So when the contrast is given, it will not take up the contrast. That's why the FNH can be differentiated from other lesions from the hepatobiliary phase. In general, how it appears, the cell will take up, so there will be enhancement, but the scar doesn't have cells, so it will not enhance. And that's how it appears. This is hyper enhancement of the hypertrophied cell, except for the central scar. This is gross pathology. This is the lesion, and this is the central scar. You see the vessels through the septa radiating toward the periphery. This again is histology. This is the central artery having branches toward the periphery. These are the hepatocyte. These are bile duct. These are Kupffer cells. Kupffer cell is not present in adenoma, and also bile duct is not present in adenoma. That's another way to differentiate between them. How it appears on ultrasound? On routine ultrasound, as I said, mostly they are hypoechoic. They will be missed on 2/3 of the cases.
They're isoechoic.
Isoechoic.
Yeah.
On 1/3 of the cases, when they are not iso, they will show up. We have, when contrast is given, on Doppler ultrasound, as there is central vessel, central artery, and radiating branches, the appearance will be like spoke-wheel appearance. And how it appears when contrast is given in the arterial phase, this lesion has centrifugal pattern. This image from contrast enhanced ultrasound in the arterial phase, as I said, in the lesion, we have a central artery. The first thing that enhances is the central artery. Here's the central artery. And gradually, it will go toward the periphery enhancement. And in opposite to FNH, where it started from the periphery.
Opposite to hemangioma.
Hemangioma, sorry. This starts from the center toward the periphery. This pattern of enhancement is called centrifugal. This case of FNH, a young woman with normal liver, there's an isodense lesion. In the arterial phase, it's homogeneously enhancing. On the portal phase, it sustains the contrast. But why it appears as if it disappears? Because in the portal phase, the liver also enhances, as 80% of the liver is supplied by the portal vein. So don't think that there's washout of this lesion or disappearance. There is contrast sustained in the lesion. Here's MRI. This type is extracellular agent. Again, there is enhancement. This is pre-contrast. In the contrast, there is enhancement, except for the central scar. In the portal phase, again, there is it's iso to the surrounding. In the by 5 minutes and 10 minutes, there is enhancement of the scar. Why? As I said, because it has malformed bile duct. So there's lower biliary excretion. By that time, it's excreted into the bile ducts that are present in the central scar. So there is delay enhancement. Okay, on T2 there is
It's slightly hyperintense or iso-intense to the
Yeah.
surrounding liver, with the central scar appears hyperintense because
it's watery.
it contains water. Okay?
This is comparison between CT and MRI. You see how MRI is superior in showing the central scar in comparison to CT. You see the central scar is on delay phase. How nicely it appears. It's hyperintense. Here's another image in hepatobiliary phase. I talked about this. This is very nice. That's why I put it here. All are from hepatobiliary phase. Hyper enhancement except for the central scar.
Nice. And this is again central scar, central scar, central scar. And I think this is the delayed phase.
Does it require follow-up? It's a benign lesion. Usually doesn't require any follow-up if it's correctly diagnosed. The second lesion is hepatocellular, third lesion, hepatocellular adenoma. It's again a benign hepatic neoplasm in young women who are on long-term oral contraceptive pills. Unlike FNH, they bleed and rupture and also have malignant potentiality. We have 4 types: inflammatory, HNF1 alpha, and beta-catenin mutated HCA. The first one is the most common, HNF second most. Beta-catenin, this one occurs in males. I said it occurs in female that are on OCP, but the fourth type occurs in male who are on anabolic steroid and has potentiality to change to malignant lesion. It has variable appearance, hyperechoic, hypo, isoechoic.
Good. So there could be hyper, could be iso, could be hypo.
Yeah.
And that's will make our life difficult, huh? It can be hypo, hyper, or iso. So it can be anything.
In pre-contrast, it is iso here. Mm-hmm. In post-contrast, in the arterial phase, it's enhancing, but the pattern of enhancement is heterogeneous. And this heterogeneity is not like the one that occurred in FNH. It's not explained by a central scar. It is too heterogeneous to be FNH. In the portal phase, there's washout.
It's slightly less dense than the liver. Okay.
Unlike FNH that it was
enhancing more on the delay.
Yeah. Okay, this is a comparison between the two lesions, FNH and HCA, because there is overlap between them in the imaging features. This is the pre-contrast. On the post-contrast arterial phase, you see both of them are enhancing. If you were given only the arterial phase, you wouldn't be able to say which one is which one. So you need other images of the later phases. You see in the hepatobiliary phase, this one retains the contrast because there's OATP transporter on the surface of the cells, but this doesn't retain. That's one way to differentiate between them. Management of HCA, it depends on the subtype, size, and complications. As I said, the fourth type beta-catenin occurs in male and has malignant potentiality, so it has to be resected. If there are complications, bleeding, rupture, then again, it needs to be resected. Now, the benign lesions, we are done with them. We go to the malignant ones. The most common primary hepatic malignancy is hepatocellular carcinoma. It's more common in male. The risk factors in most of the cases is the cirrhotic liver, but it can occur in non-cirrhotic liver in old age male. And also there is increased serum alpha-fetoprotein. These are the risk factors, causes of cirrhosis: hepatitis C, alcoholism, non-alcoholic fatty liver. In non-cirrhotic livers, these are the risk factors. In non-cirrhotic liver have bimodal age distribution, more frequent in male. As I said, the non-cirrhotic type mostly in male and old age. The most common risk factor is hepatitis B. Without going to cirrhosis, it just the malignancy starts once there is hepatitis B. Not once there is hepatitis B, but it doesn't before it becomes cirrhotic. It will have malignant.
So it can cause liver cirrhosis, then develop to hepatocellular carcinoma, or hepatitis B can cause hepatocellular carcinoma without cirrhosis.
Yeah. On ultrasound, it's hypoechoic. In the arterial phase, it is hyper.
Arterial phase of what?
CT.
Of CT scan. It shows some contrast enhancement.
Here, it shows washout of contrast. Washout of contrast is very specific for malignancy to detect whether it's malignant or benign. Regardless of the arterial phase or the portal phase, if you see washout, you should think of malignant lesions. Because if you remember in hemangioma, it was even filled in with contrast. In FNH, it was iso to the background liver. But here there is washout. You see, it is less dense compared to the surrounding liver. Sometimes there is not washout, but there is a capsule enhancing. This pattern of enhancement is not like the hemangioma, not nodular, not discontinuous. It's like a capsule. It's basically capsule.
So when we see a capsule, usually we feel good, but not in this type. When you see capsule, that's suspicious.
And you see the liver was cirrhotic.
And in these cases, be careful when doing the biopsy because 99.9% the patient will be hepatitis B positive.
Again, you see, there's a capsule. It has two criteria, basically, depending on the size. If the size was large, only one of the criteria is enough to say it is malignancy. But when the size is small, only one of the criteria. And what are the two criteria? Either there is washout or either there is no washout, but there is capsule. In this lesion, there is only capsule and there is no washout. You see how the lesion is similar to the liver. This lesion is being 10 to 90 millimeter. It is smaller than the other one. So it has to have two criteria, both having capsule and washout. And this is a huge lesion in an old man with a normal liver, but it came out to be hepatocellular carcinoma because it is when being an old male is the risk factor for me having SCC.
Good. Just because he's a male, it's very risky.
This is fibrolaminar HCC. Fibrolaminar HCC, like FNH, has central scan.
This is the most difficult one to diagnose, in my opinion.
Yeah.
Why?
Because it looks like FNH, but in hepatobiliary phase, it doesn't take up the...
First, we don't have the liver-specific contrast here. So we cannot use this criteria, the hepatobiliary and whatever. Second, the fibrolaminar carcinoma is in young patient.
Yeah.
Okay. Which is the same thing as FNH. Again, it's in the young patient. Okay. So, and they look the same. So it's really difficult.
Maybe by biopsy.
Yeah, by biopsy, definitely. But it's not easy to do the biopsy. You have to come up with a differential diagnosis or something. Anyway, one of the things. Yeah, but it's not common, but it happens. One of the things that might help to say that this is a fibrolaminar carcinoma rather than other lesions, they tend
calcification.
Exactly. Yeah. They tend to have calcifications. So if you see calcifications in a mass that otherwise looks like FNH, think fibrolaminar carcinoma. Then biopsy is definitely indicated. If there are no calcification, you have to follow it up for few weeks or months. If it's increasing in size, think fibrolaminar carcinoma. Got it?
Metastatic lesion. Metastatic lesions more common than primary lesions in the primary malignant lesions. Incidence increases with increasing age. The radiographic features vary depending on the primary malignancy. In this case, what has occurred? Here is the arterial phase. There is peripheral enhancement. Okay. Heterogeneously enhancing it is. In the portal phase, what has happened?
It's iso-intense. It's the same enhancement as the liver. Okay?
Yeah, it's iso-intense. In the delay phase, what has occurred? There's washout from the periphery. And the center kind of enhancing. It's representing the center is being ischemic. That's why there's delay enhancement. Here again, there's a peripheral enhancement.
But it's continuous.
Yeah.
It's not interrupted. So it's not a hemangioma. It has a necrotic center.
You see, it's been hyper enhancing in the late phase, but why you can say it is hemangioma? It is not discontinuous like hemangioma in the arterial phase.
By the way, before you start with the cystic lesions, the vast majority of liver metastases are multiple. Very unlikely. It happens, but very uncommonly that we see single liver metastasis. It can be anything. Can be hyperechoic, hypoechoic, isoechoic, can be central necrosis, can be vascular, can be avascular. Anything is possible. Okay? So, multiplicity is in favor of metastasis. Presence of a primary tumor, patient known case of breast carcinoma, method, or colon cancer, or gastric carcinoma, again in favor of metastasis. Okay? And the enhancement mainly it's on the periphery or intense, mostly in the which phase? Metastasis.
The peripheral?
No, the enhancement
Arterial.
starts at the arterial phase. So when you are suspecting metastasis, make sure to look carefully to the arterial phase. Okay?
Cystic liver lesions. Now we are done with the solid lesions. We talked about benign and the malignant ones. Now we go to cystic lesions. Again, we have benign and malignant. I only talk about the benign one, which are simple cyst, abscess, and hydatid cyst. The malignant cystic lesions again subdivided into the primary and secondary subtype. The primary one is biliary cystadenocarcinoma, which I'm not gonna talk about this, and the primary ones mostly from colon and pancreatic.
What about ovary? Ovary is not cystic?
Ovary too.
Yes. Ovary, it's more, it's cystic, but it's called mucinous أكثر. يعني thick content, content cystic metastasis. Okay? Yeah, but
I only choose few lesions. It doesn't mean other lesions are not existing.
Anything can be anything. You can have colon cancer with cystic metastasis. You can have gastric cancer. Unlikely, but I'm sure if you read in the journals, you'll find the case report here or there.
Simple cyst anywhere has 4 criteria to say this is a simple cyst. In liver, not in just liver, anywhere, as I said. The criteria, it is sharply defined margin, has a thin wall, anechoic, the content, doesn't have septation, doesn't have calcification, enhancement, or mural nodule. These are the criteria for simple cyst. It is congenital, detected late, isolated or associated with congenital cystic disease, like polycystic kidney disease, cystic disease elsewhere, and usually asymptomatic. If they rupture, they cause symptoms.
And they can be
a few millimeters to several cm.
Yeah.
Next lesion is hepatic abscess. They're usually indolent with no signs of infection. may present with profound septicemia. The abscess usually have thick walls and homogeneous low attenuation. At the periphery, there is a halo. Pyogenic abscess has marginal enhancement, you see. Gas containing, here, this abscess is gas containing.
It shows air fluid level depending on the organism, or if previous intervention like previous aspiration or whatever, this will be air fluid level.
On MRI, it's low signal in T1, in T2 high signal. In contrast, there's peripheral enhancement.
So how do we differentiate abscess from cyst on MRI?
It doesn't have peripheral enhancement.
The cyst shows no enhancement. Yeah. So you have to give contrast. Okay? What's the most common cause of liver abscess? The most common is amoebic abscess.
Yeah. Hydatid cyst is caused by Echinococcus granulosus, well defined, could be unilocular or multilocular. There is calcification either central or peripheral.
No. Peripheral.
Only peripheral? Yes.
It contains fluid.
I thought the daughter cyst, there is possibility of...
The wall of the daughter cyst can calcify, but it's again the wall of the cyst, not central.
I mean the wall of the cysts which are in the center of the larger cyst.
So it can be unilocular cyst or can be large cyst containing multiple daughter cysts. Calcification can happen in the cyst wall or in the walls of the daughter cyst, to be more obvious. Okay.
These are the daughter cysts. This is CT. It is a large cyst containing smaller cysts. This is the calcification we talked about.
No, this is not the calcification we talked about. What? No, it's a calcification, but not this is in the periphery and in the center. So why is that? Is this hydatid cyst or not? It's hydatid cyst.
The walls are enhancing.
No. This hydatid cyst has multiple stages. Stage 1, 2, 3, 4. As it evolves, it will get, if the cyst dies, it will crumble, collapse. And with time, it will be calcified. So if you wait for like 1 or 2 years more, you'll see this as dense area of calcification, just like a stone or something. Just something calcified in the center.
Is it necessary to wait that long? Sometimes
we can manage. Yeah, we can diagnose it early, but if you see something very dense, calcified in a patient with known history of hydatid cyst, it's dead cyst, it's collapsed, it's calcified. Leave it. That's it.
So calcification rules out living cyst.
Yeah, exactly.
Here you see the floating membranes. This is pathognomonic for hydatid cyst.
What's the name of this sign?
Crumpling. Water lily.
This is water lily sign. They float on the surface. Okay.
And in later stages, it will crump. It will be in the dependent part.
Exactly. It will fall.
It's called sunburst or sunrise.
Whatever. Sun. It's something sunny. Okay. So again, the water lily sign is very pathognomonic on ultrasound, on MRI, and on CT scan. Of hydatid طبعا.
Here's in T2 MRI. It's hyper intense because it is water in the cyst.
So you didn't tell me what is the contrast enhancement of the hydatid cyst. What did you say?
I thought there is enhancement in the wall of the cyst.
In the wall.
I'm not sure.
So let's discuss it. If it's a cyst and it's a parasite. So why would the wall be enhancing? It's not from something that is not from our body.
It's not
will not
it will not enhance.
صح?
Yeah.
Yani if you put a bullet in the body and you inject contrast, the bullet will not enhance. صح? And this cyst is not from the body. So why it will enhance in the wall? A hydatid cyst, it's surrounded by a fibrous capsule from our body. The fibrous capsule, it's from us. It belongs to us, to our body. Okay? So the enhancement that you see, it's not the cyst, it's the fibrous capsule of our body. Okay? But since it's in very close contact with the wall of the cyst, you think that the wall is enhancing. But it's not the wall, it's the fibrous capsule that the body forms to protect the cyst from rupturing and, contain it. Yeah, it starts as pericystic inflammatory changes that matures into fibrous capsule.
It's like a mechanism, any defense mechanism.
Exactly, defense mechanism to keep the cyst there,
To localize it.
to localize.